Hello, I'm Dr. Asif, one of the surgical candidates. You know that recently I have been passed MCPS and also going to start for FCPS part 2. So I may face some difficulties in the exam because I have passed in multiple times, not a single time. That's why I know where the students are struggling for being passed. So as the continuation of my playlist, this is the one of the important topic where a huge Viva board is occupied by the surgical specimen and their question and answer. Yeah, I have tried to collaborate some information regarding the surgical specimen, but there are a lot of things is yet to be constructed, like carcinoma, stoma, colon, and others. It will be discussed with the advanced surgical specimen lecture. So here the first few fundamental things, which is very important or very basic to face Viva. So let's start. Okay, the first one is appendix, which is very common in case of MBBS exam and also the MCPS and FCPS exam. So what it is, so identify the specimen. So this is the inflamed vermiform appendix, and describe the lesion, like red, swollen and congested appendix, engorged blood vessels here in the surface, and the tip is somehow color changed, so this is called almost gangrene. Okay, because you can see the violet color here in the tip. And so what is the diagnosis? This is acute appendicitis, and the clinical presentations should be the pain around the umbilicus and shifted to the right iliac fossa, anorexia, nausea, vomiting, fever, and what will be the sign? That is pointing sign, tenderness in the right iliac fossa, rebound tenderness, and the Rothstein sign, Swas sign, obturator sign may be present in case of examination. And causes of acute app, like what will be the acute sign? Like it is more like intestinal obstruction. You can see it could be happen due to impacted feces, worm, like interluminal impaction of worm, malignancy, lymphoid hyperplasia, structure like intramural stricture, bands, addition and extraluminal features. So what may be the other possibilities? Like in case of female, rupture ectopic pregnancy, then torsion of ovarian tumor, torsion of fibroid, PID, endometriosis. This may not be excluded, because in case of female, you must know these things can be happen. So it is very important. And other complications should be gangrenous appendicitis, burst appendix, peritonitis, and appendicular lump. So these are the complications. If you not detect it in the appropriate time period, then it become gangrenous appendicitis and burst appendix, peritonitis, and appendicular lump. And appendicular abscess also, septicemia, septic shock. So what are the investigations? There is no specific investigations which is absolute for appendicitis diagnosis, but we can assess there should be an appendicitis by different investigations, like CBC, that is complete blood count, erythrocyte sedimentation rate, like ESR raised, X-ray, erect posture, AP view to exclude perforation, and also USG ultrasonography, which is more cheap available, and urine RME to exclude UTI, serum amylase, lipase to exclude acute pancreatitis. And now you can see some open appendicectomy. So what is the treatment? Appendicectomy. It should be done by open or laparoscopic method, but still now open method is the gold standard. Okay, we can see this is the transverse colon, ascending colon, descending colon. So this is the specimen of colon. So you can see there is a lesion in the cecum. So this is the cecum. So this is the part of the colon, and here there is a lesion in the cecum. It's called a tumor. So Diagnosis carcinoma cecum, and investigations should be done at a colonoscopy, biopsy, and histopathology, tumor marker, USG of the whole abdomen, CBC, anemia. Yes, you have to know that right-sided colonic tumor presents early with anemia, that is iron deficiency anemia, and the left-sided colon malignancy is detected with weight loss and constipation and abdominal distension first. And what will be the incisions? That should be a middle midline or lower midline incision. So preoperative preparation. So before operation, you must evacuate the gut with the proper gut preparation, and also the correction of the anemia, electrolyte imbalance, and also nutritional status. So multidisciplinary team approach, and you must discuss with the patient or counsel the patient about the treatment protocol, prognosis, and the outcome. And you must counsel about the proper chemotherapy cost of this treatment process, and also multidisciplinary team should be involved, and it is very important. Okay, so correction of anemia, dehydration, okay, that is eminent. Then correction of fluid and electrolyte imbalance, and IV fluid, prophylactic antibiotics, bowel preparation, 3 days preparation, low residual diet, and liquid NPO, nothing peroral, antibiotic, neomycin, laxative, and enema. So laxative and enema, which is important, you can use sodium picosulfate or mannitol can be used for it act as a diuresis, and also act as a laxative. Okay, so both can be used, and there are other solutions like phosphoprep preparations, also the osmolax preparation. So these are the broadly it can say that it is a laxative or enema. Okay, what you can see here, this is the huge distended tire-like shadow from the abdomen, is most likely the sigmoid volvulus. So if I say to postoperative, that is huge distended tire-like lumen of the large gut, that is sigmoid colon, and this patient has absolute constipations and pain, abdominal pain, vomiting later on. And what is the option? That is laparotomy is the answer. And if the sigmoid colon is not so distended, then you can derotate the sigmoid colon and make a sigmoidopexy, or a sigmoid colon attached to the gut wall to prevent derotation, to again rotation. But in this case you have to resect it because it's a closed loop obstruction, and there are huge distended area and causes some fluid which is toxic, and also it has some bowel gas and liquid and chemical substance which is toxic to the body. If it goes proximally or in the attached with the in the blood circulation, it can cause septic shock or septicemia. So if viable, sigmoidopexy, and if not viable, dissection anastomosis of this segment, and also the Hardman procedure or Paul McCulley's surgery, that is double loop, double opening, proximal distal one comes through the percutaneous area, that is called Paul McCulley's. On the other hand, you can use Hardman's procedure. So what is this is the pathological specimen of the resected gallbladder with stone in the gallbladder. So what you can see, some wall is distended, edematous and thickened, and multiple numerous stone is seen within the lumen. And the diagnosis, chronic calculus cholecystitis, that means cholelithiasis. So we can see it as a calculus cholecystitis. Okay, symptoms should be repeated episodes of right iliac fossa pain, and because it has a huge stone, there should be a pain. But sometimes some cases are painless because it is sometimes diagnosed by in the ultrasonogram of the whole abdomen incidentally, and after fatty meal, fatty food intolerance, anorexia, nausea, vomiting, and mild fever may be present. And if it is an acute cholecystitis, in that case Murphy's sign, present because it is chronic, so no Murphy sign. Gallbladder is impalpable. Shrunken because wall is edematous, thickened, and gallbladder cannot be distended due to the huge inflammation or fibrosis. Most important investigation of diagnosis of case is a whole USG of the whole abdomen with special attention to gallbladder and bile duct. And the pre-op USG findings of the condition, hyperechoic structure, casting posterior acoustic shadow, and gallbladder is shrunken and contracted. What operation is done? Cholecystectomy. So indications of operation involve the chronic cholecystitis, cholelithiasis, choledocholithiasis, mucocele of the gallbladder, empyema of the gallbladder, carcinoma of the gallbladder. So these can be happen as a complications. And what are the complications of operation? At a hemorrhage, injury to the liver, bile duct, GIT, pancreas, and acute pancreatitis. So infection should be cholangitis, hepatitis, and intestinal obstructions, and failure to removal causes septicemia, septic shock. Because sometimes if you don't treat the gallbladder disease, it can arise disease to the another organ like pancreas, because gallstone can causes gallstone pancreatitis. Sometimes it can causes jaundice and causes hepatitis. So cholangitis. Okay. So complication of gallstone, we already I already told you that Mucocele, empyema, erosion, perforation, then acute cholecystitis, chronic cholecystitis. So this is very common. It could be present anywhere. So effect of gallstone impacted in neck of the gallbladder, and so it can cause a mucocele. So how mucocele form? Mucocele then first stone impacted in the gallbladder, then proper bile cannot be extracted, so it is accumulated and reabsorbed by the wall, and then it secretes clear fluid, and that is called mucocele. So when bacteria inoculate in the mucocele, it can become empyema of the gallbladder. Okay, so mucocele infected, then empyema. So effect of gallstone impacted in the CBD. If some minor tiny gallstone can pass through the cystic duct to the common bile duct and causes choledocholithiasis. Okay, and which is important causes of obstructive jaundice, or the causative options of choledocholithiasis. What type of stone seen within the lumen? Here you can see the black stone or pigment stone, okay, or brown stone. But mixed stone is very common in case of gallbladder. What are the factors responsible for formation of gallstone? That is fat, obesity is important, whatever it said, causative factors, obesity, and estrogen, that is combined pill or OCP, reproductive ages, because patient has multiple pregnancies, so patient must go through the sedentary lifestyle, so gallbladder contraction is impaired. That's why stone is formed within it. Okay. Hemolytic anemia, yes, in case of thalassemia, sideroblastic anemia, or hemoglobinopathy, sometimes early breakdown of RBC can causes more bilirubin and biliverdin formations, and most bilirubin levels, biliverdin level may causes pigment stone. Okay, so here this is the mucocele of the gallbladder. You can see the gut wall is distended, thinned wall, and pear shaped, hugely distended, and normal color. And you can see gallbladder is distended and vascularity is visible. So this is the resected specimen. Cholecystectomy has already been done, because you can see the gallbladder is resected. And if you say what two investigations you will detect to as a gallbladder disease, that is ultrasonogram and also the MRCP or CT scan. Okay, I already told you these things in the previous slide. Okay, I'm going to skip it. So as you know, you can see the wall is edematous and whitish and causes it seems that a pus within the gallbladder because it is the infected form. So you can see a huge pus came through from the gallbladder. So its treatment is the antibiotic, analgesics, and also cholecystectomy. Okay, so this is one of the acute conditions, so its outcome is questionable. So you can see this is the ruptured spleen or splenic specimen. So there are multiple tiers of the specimen. So you can see this is a blunt trauma injury, I think, or a stab injury through the ribs in the 9, 10, and 11 positions and causes ruptured spleen. So it should be removed. And splenic rupture. So this patient might has hypovolemic shock due to excessive blood loss and causes hemoperitoneum or blood in the peritoneum. Causes tachycardia, hypotension, cool clammy skin. All the features of shock will be present, and balance sign, feel dullness over the left upper quadrant. Card sign, that means right supraclavicular region there is a pain, shoulder tip pain. That means diaphragm is irritated somehow because cervical 3, 4, 5 is the phrenic nerve origin point, and it gives supply to the diaphragm. So if any diaphragm irritation, pain can causes through the cervical 3rd, 4th, and 5th. So Caird sign means the referred pain tip of the left shoulder or right shoulder. Okay, so investigation should be the first scan. First scan, this is immediate focus ultrasonogram, sonar for trauma, and USG abdomen, X-ray abdomen. Here CT. Why not CT? Because CT needs some time to make it perform. It is costly and not available in every hospital. In that case, ultrasonography is the only choice. So we will do for as a trauma case. Recent ATLS guideline, if fast scan is the choice of investigation. Not here. And then the USG abdomen, X-ray abdomen, hemoglobin percentage, because it is a hypovolemic shock, that's why hemoglobin percentage must be checked. So ABO and RH typing. So mention the treatment, that is splenectomy, here done, and this mesh repair can be done here in few cases, but no need to mention. It is called the splenectomy. Okay, so indications of splenectomy: this is splenic rupture, splenomegaly, thalassemia, part of the other operation like CA stomach, CA pancreas, CA left colon. Because this kind of operations, so spleen may be found surrounding these 3 structures: stomach, pancreas, and left colon. So during dissection, we sometimes spleen can be ruptured. So en bloc resection can be done during gastrectomy or left hemicolectomy, sometimes in the tail of the pancreas. Okay, so what will be the pre-operative preparations before splenectomy? You must make 1 or 2 blood, whole blood, maybe instant present in the operative field, because any situation can be happen. You can't see the viscera in the meantime, so there will be a continuous bleeding. So 2 to 3 whole blood must be present, and correction of anemia, dehydration, nutritional balance, and you must perform coagulopathy, antibiotic prophylaxis, and vaccinations. Yes, because OPSI, opportunistic bacterial infection, is one of the important problem. So 3 encapsulated bacteria is more commonly infect as in any splenectomized patient. That is Haemophilus influenzae, Neisseria meningitis, and Streptococcus pneumoniae. It is very important for MCQ also. Okay, so avoid travel to malaria or cholera affected area. Yes, because you have a limited immunity, because splenic is one of the important immune organ. So as it is resected, so your immunity will be less than a normal person. So important post-operative measures, so you should take vaccine before go to any endemic area, and also some lifelong vaccination is needed for after splenectomy. Most important post-operative measures: long-term prophylactic antibiotics is done, regular vaccinations, and avoid travel to malaria, color zones. Okay, now this is one of the important specimen which is very important, like RCC or renal cell carcinoma. So you can see multiple here, some tumor in the cortical region, also the cortical region in both kidney. Okay, horseshoe shaped kidney it look like, and cortical there is a proliferating ulcer proliferating growth in the cortical area, and it has central necrosis seen in the centrally. So area of hemorrhage, you can see some clot here. So renal cell carcinoma, diagnosis renal cell carcinoma. So what will be the clinical features? Should be painless hematuria, low in pain, then polycythemia due to more erythropoietin, because erythropoietin is formed from the kidney. So as it is mutation happen, so erythropoietin will be more. In that case, patient might causes polycythemia and also raised blood pressure, and due to more vitamin accumulations, so hypercalcemia and hypertension due to more renin formation. So investigation confirm ultrasonography of the whole abdomen and Doppler study to know the vascularity, and also the contrast CT contrast enhanced CT scan, which is more gold standard. Also you can perform CT ranogram. Okay, so treatment modalities of renal cell carcinoma will be surgery, because RCC is chemo and radio resistance. So the only option is the surgery and followed by radiotherapy. And you can see the staghorn calculi. The stone is look like horn of a deer, male deer. That's why, and it's it present in the whole pelvis of the kidney. So the only options is non-surgical measurement, that is ESWL. Then stone is extracted by Dormia basket, or if the minimal invasive technique, that is percutaneous nephrolithotomy and also the open nephrolithotomy. But here the most of the, and you must perform kidney functions test, that is RFT. If RFT is normal, you can keep your kidney in that side, but if it is not present, if you see there is no IVU, when you inject IVU or dye cannot pass, that means the kidney function is impaired. In that case, nephrectomy is the only option. Okay, so staghorn calculi means it has a triple phosphate stone, because calcium, magnesium and ammonia phosphate. It has Struvite stone is called, because Struvite stone is happened due to Proteus bacteria. It has been seen that Proteus, infection of the Proteus, if it happens, then staghorn calculi or Struvite stone is raised, because it has triple phosphate, calcium stone, oxalate stone and xanthine stone, calcium, magnesium and ammonia, sorry. And the renal stone, there are other renal stones, right? Calcium stone, oxalate stone, xanthine, ureate and phosphate stone. Causes of the type of the stone, what are the types? Infection with Proteus and decreased water intake. So it's an advice that you must drink a lot of water to prevent any stone formations, because kidney has the work to excretory function. So if you give him a lot of flash of water or increase water supply, so there will be no chances to form a presence of bacteria, presence of any metallic substance or any salt or any metallic substance. It will be washed out by a lot of water. So water drinking is preventive for any stone formations. So you can see this is the X-ray KUB. So and you can see the dye is seen through here. So it is so you can see the staghorn like calculi present. Also KUB X-ray shows hyper opacity in the both side or single side of the lumbar vertebrae. So this is the X-ray is very important for stone detection. Also, if it is not seen like uriate stone, because uric acid stone sometimes radiolucent, you cannot see in your X-ray. But if you perform IVU or CT tenogram, you can find out uriate stone. So prevent fluid intake, limit tea and coffee, and maintain hygiene. So complications if untreated, hydronephrosis can be happen, because if any stone obstruct the pelvis or major or minor calyx, it can causes impairment of the excretion. That's why backflow pressure raised and kidney become enlarged, and this situation is called hydronephrosis. And infection, pyonephrosis, pyelonephritis, perinephric abscess, and paranephric abscess, etc., and also the renal failure. Okay, so here you can see some bladder stone. It's like egg of ostrich, right? So sometimes whitish, round shaped, and smooth surfaced, but strong. This kind of stone is seen in the bladder. Regular margin. So the pain will be felt in the tip of the penis, because trigone is irritated. So trigonal irritation will be felt in the tip of the glans penis. And the pain during micturition, yes, because all pain is felt due to the irritation of the trigone. And the hematuria, LUTS, and the investigation will be X-ray, KUB, IVU, and USG, KUB, urine RME, serum urea, and creatinine. It should be done. Okay, so composition will be calcium, oxalate, xanthine, and uriate stone and phosphate stone. So general treatment will be antibiotic, analgesics, and the fluid intake. Yes, and specific lethal apexy, crush stone, take piece up through small opening, and pariurethra. That is ESW and forming stone extraction by Dormebus. But also lethal apexy, crush stone with the pneumatic lithotripsy device, and take piece out through small opening as pariurethra, and open cystolithotomy, that is through the abdomen, like suprapubic cystostomy, cystolithotomy, suprapubic region is very common. And here in this right side, you can see the two testes. One testis is blacking, and another testis is normal. So this is a torsion of the testis. You can see there is a torsion happen here, and three features. The right testis is swollen, and the right testis is shiny and engorged and prominent veins. And diagnosis, torsion of the right side of testis, and condition will be anatomical abnormality like bell club deformity, abnormality high up testis, straining for micturition, trauma, and running and exercise. Traumatic accident is not so common. Straining in micturition, it can be happen, and abnormality in the high up testis, yes, it can happen. Clinical features, sudden severe pain and vomiting, testis high up, and increased pain, testis become swollen and tender. Sometimes patients become vomited, okay, due to the pain, and sometimes patient is very violent, and he cannot let it be touched, and if make it elevated, the pain is more severe. But in case of epididymoarthritis, if you elevate the testis, the pain is reduced. Okay, so two-step surgery, that is detorsion or detorsion of the testis, and they check the viability. If not, then orchidectomy, and you must make another testis fixed with the valve, that is orchidopexy of the another testis. Why? Because this is the lost. If this happens, if this rotation happen in the remaining testis, so viability is vanished. So to prevent testis rotation of the another testis, we must perform orchidopexy. Okay, what is it? Testicular tumor. You can see huge testis become swollen or enlarged, and some homogeneous appearance, and also full testis become a tumorous. So bulky mass occupying whole testis, cut margin white homogeneous is called seminoma, seminomatous mostly. And if you say what is the histopathology, it is germ cell tumor. And what investigation? USG and lactate dehydrogenase, alpha peritoprotein and beta HCG, and biopsy and histopathology is the treatment investigation of choice. And what are the treatment options? That is surgery, that is orchidectomy by the inguinal approach. You must not go through the scrotal approach, because during extraction of the tumor, some tumor tissue may left over to the scrotal wall, and secondarily tumor can be arise from in the scrotal wall. That's why we will perform incision in the inguinal region to remove the testis, followed by chemotherapy and radiotherapy also. Okay, so the another things is, you can see this is the specimen of the breast, and you can see the nipple and areolar tissue, and also some external skin appendages. Appearance becomes orange, pod orange. Okay, nipple is retracted inside. So you can see, so you assume that there is a lump under the retracted area, and this pod orange can be happen due to the lymphatic obstructions. So this is the carcinoma breast, and lump during examinations point, you can see the hard lump, fixed irregular swelling under the nipple. The risk factor, though, you must find the risk factor: family history, early menarche, late menopause, nullipera, obesity, or any evidence of radiation happens or not. And sometimes spontaneous. What is a triple assessment? Triple assessment, clinical assessment like age, lump, and risk factor. Imaging, mammography, ultrasonography, mammography, and pathology, the FNAC, final aspiration, cytology, and a biopsy. Modern investigation, carcinoma diagnosis, imaging. So you must perform imaging first, then pathology from above. Like what is it? Like you must perform immunohistochemistry, and you have to make a typing of your malignancy, like it is ductal cell carcinoma or invasive carcinoma. Is there any receptor sensitivity present or not, like estrogen, progesterone, Herceptin positive or negative? So you must perform immunohistochemistry after the FNAC. Sometimes FNAC is inconclusive. In that case, you must perform core biopsy and take some tissues, and must perform immunohistochemistry, because sometimes patient came with late stage and tumor is much more bigger, so we must perform modified radical mastectomy. But if we want to see the receptor is positive, like estrogen and progesterone is positive, in that case we can use some biological agent. You can use some medications like methotrexate for 5 months or 6 months or 5 years to make the reduction of this of the tumor size. Sometimes Herceptin may be positive. In that case, trastuzumab or biological agent can be used for better management. And then you can, when the tumor size is reduced, you can perform breast conservative surgery and sentinel lymph node biopsy. If lymph node is positive, in that case we will go for axillary dissection or axillary workout, and if it is not, then you can done wide local excisions or like BCS and quadrinectomy also. So that is all the operation, that is MRM or modified radical mastectomy, and tamoxifen hormone sensitive tumor, if it's a positive good tumor, in that case tamoxifen can be given. Or earlier localized advanced breast cancer, so distant metastasis surgery is not possible, in that case radiotherapy or chemotherapy can be used. Here it is a skin lesion. You can see the if it is an ulcer, so if you describe an ulcer, the margin is raised and everted and centrally necrosis, and that's it is ulcerative lesion, shape irregular. So picture margin is regular, raised, edge everted, so centrally fast, slot blood, and temperature absent, base indurated, hard and non-tender. So this is a malignant ulcer or non-healing ulcer. Another things should be basal cell carcinoma, TB or syphilitic ulcer. So point of examination ulcer as seen above. I will discuss a short case here like as a lecture within 5 to 7 minutes. How can you describe an ulcer and also give them an answer following the short case. I will discuss with another lecture, okay, with the ulcer lecture, okay. And so treatment should be wide local excisions through 1 centimeter tumor free margin, and or if it is more huge, in that case flap, or if it is smaller, in that case you can see graft or flap can be given if the ulcer area is more enlarged. Lymph node, we will find the lymph node or draining lymph nodes, so lymph node should be excised. And in case of ulcer in the limb, or it is more extensive or aggressive, in that case amputation should be done in some cases, not all cases, but in some cases. And this is another one, is a basal cell carcinoma or malignant melanoma, because it's a black tumor, it should be a melanoma. And you can see here the external area of the nose, it should be a basal cell carcinoma. So nodularity or ulcerative both can be happen. Shape irregular, margin irregular, rolled and everted, yes, rolled and everted. Indurated hard lymph node. So basal cell carcinoma, if ulcer present, may be white rodent ulcer. So another day I will discuss with a story why it is called rodent. Rodent means a rat, okay. Why this ulcer is similar to a rodent ulcer. So there's a story behind the rodent or BCC. Okay, so another day I will discuss with you. And the DD should be squamous cell carcinoma and ulcerative causes, and confirmation should be biopsy and histopathology. Treatment modalities with wide local excisions with tumor free margin, and follow up by graft and flap and radiotherapy. Prognosis of this case, good prognosis. Why BCC is very prognosis is good? Because basal cell malignancy has no any blood supply or lymphatic supply. That's why it is a locally malignant tumor. So tumor is present locally. So if you excise the tumor, okay, and this malignancy is removed, okay. So here this is the blackish irregular margined area of the skin, and it is a nodular black area along with the normal skin. So it is a malignant melanoma, highly aggressive sometimes, and it has some other subtypes in different regions, like nodular, like superficial spreading, like acral melanoma, palm and sole, and amelanostic melanoma. So there are different 5 to 6 types of melanoma, and including most common superficial spreading and most aggressive is nodular melanoma. Also it is a nodular melanoma, this is superficial spreading type of melanoma. So it could be arise from the benign nevus or mole, and then it transformed into malignant melanoma also. And sometimes it is associated with squamous cell carcinoma. So same and diagnostic protocol should be biopsy and histopathology, and the management should be wide local excisions, okay, wide local excision of the tumor with tumor free margin, and tumor free margin will be counted as a Breslow thickness classifications, okay. So it will be discussed in the short case class about malignant melanoma. I will discuss with a diagram of Breslow thickness classification. So yeah, you will see in that lecture also about in details, okay. So if the lesion is much more enlarged, in that flap or graft is needed, okay, or if it is small, in that case primary closure can be done, okay. So here in squamous cell carcinoma spread by lymph node, no role of chemo and only surgery. In case of BCC, locally malignant, no role of chemo and only surgery plus radiotherapy. And melanoma spread by blood, surgery, so radio, chemo, both is needed. So this is a giant cell tumor. You can see the giant cell, because in the X-ray class I have shown you guys about the X-ray of the wrist with the giant cell tumor. So you also you can see this is the wrist. So you can during dissections you can see osteolytic lesion. Also you can see some sequestrum, right? Because it's a chronic osteomyelitis, there is a new bone or dead bone within the living bone, which is called the sequestrum, can be formed within the giant cell tumor also. Sequestrum is the dead bone lied within the living bone. It is the hallmark of chronic osteomyelitis. Okay. And sequestrum is formed by the bacteria Staphylococcus aureus, radio-opaque shadow present. So antibiotic. So what is the treatment protocol of chronic osteomyelitis? Curated sequestration and saucerization. Okay. And splintage sometimes. If the lesion is more wide, in that case flap or graft can be done, and pathological fracture sometimes present in that affected bone lesions, and growth distance deformity and lymph length discrepancy. So that is all about today's lecture. Yes, it's a part 1. It will have another one like that consists of stomach cancer, colon cancer, rectal cancer, and also the liver specimen with different diseases. So there will be another one later on, but it's initial but most covered points I have gathered here. So I think you try to see again and again to make it recapitalized, and also it needs to memorize as early as possible. Thank you very much.